Oh, hey, Chris.
Hey Chuck, how are you?
I'm great. We're back at it.
We are back at it. We are in a holiday mood right now. Once you pass Halloween in the US, then all the holiday decorations start to come out. People think about Thanksgiving here in the US, but I did see literally on November 2nd, I saw somebody with a little reindeer nose on their SUV. I was like, that's really, really early.
It's really like, can I tell one funny Halloween story?
Yeah.
It's a good one. So in Missouri, and actually selected parts of Missouri. So for those international listeners, Halloween is, I don't even know what it's supposed to represent, but basically kids dress up, they walk around, they get candy from houses, and that's the celebration. It's very fun and
It's
energetic
the day
time.
before All Saints Day. It's
Thank you.
the night of the dead, I think is what the origin of it. But okay, go ahead.
Yeah.
As
Okay.
you
Thank
were.
you. Thank you. And so growing up, you just knocked on the door and people say hi and they give you candy. And where we live now in St. Louis, there's a tradition where one shares a joke or a trick or I don't know what it is, but and so there's a really strong expectation that trick-or-treaters share a joke, and they're usually really silly, not funny jokes, right? Is that do your
Maybe
kids
no,
tell
my
jokes?
my kids tell amazing jokes. So we practice them. They actually carried around their joke books this year when they did it. So
So that's the part I enjoy. And so my wife is like, because we don't have kids young enough to trick or treat anymore, which we loved when it happened. And now we're just kind of the old couple at home. And, so we live in a weird spot. We live in a busy neighborhood for trick or treating, but we're around the corner. And so we don't get that many trick or treaters. And so at like 7 o'clock, the doorbell rings. And I'm like, yes, finally. And so I go to the front door, open the door, and there's two teenagers barely dressed up who said, trick or treat. And so my wife is not with me. She's in the other room. And I said, hey, trick or treat. Are you guys having a good night? And they're like, yeah. And I'm like, all right, what's your joke? And they go, we don't have a joke. And so I said, no joke, no candy. And and so
oh, what they do to your house.
nothing, but they came up with some stupid joke and I gave them plenty of candy. And actually that was the only trick-or-treaters we had all night. And then I
Wow.
and then I walked back in the room. I'm like, she's like, my wife is like, you're a total jerk. I mean, in her mind, I'm like looking down on 6-year-olds saying no joke, no candy, which is not at all what happened. Anyways, funny.
Oh man. So interesting enough, we'll talk about the trip I was on a few weeks ago, but the in Italy, I saw a lot of Halloween stuff. I was very surprised by this. And it was there were like skeletons everywhere. I was like, wow, are we like in the States? I thought, and maybe it is. I don't know. I mean, I thought Halloween, as we think of it in the States, is very much a U.S. centric kind of thing. And maybe that is my American nationalism kind of coming coming to head. But I was surprised by the amount of Halloween stuff I was seeing abroad. But Halloween is super fun here, and my kids, I think they tell great jokes. The day of Halloween, I had just come back the day before, and I was operating, and I was really trying to get home. I was like, I need to get home. I had a case canceled the day before, and I usually would have been like, replace the case with something else. Now I'm like, oh, that's fine, no worries. Makes it even easier to get home, because I realized that my kids are going to be at a certain age pretty soon where I'm not going to be able to take them trick or treating. They're not going to enjoy it as much. They're either going to stop trick or treating, or sooner than that, they're going to want to go trick or treating with their friends and not with me. So I have like another probably 2 or 3 years from my son before that happens. I don't know when that happened in the Gold farmhouse.
Yeah, I don't know when it happened either, but it was very fun, and I do miss it. Hopefully, we'll get more trick-or-treaters next year. And we have a lot of smart listeners, so if someone can share succinctly the Halloween origins, or if you're in another country, what Halloween means to you, that would be helpful for us. So, tell us about your recent international travel.
Oh yeah, so it was great. It's been a little bit now, but I was in Torino, Italy, for the 2024 meeting of the Naracas Club, which is named after Naracas, who is an incredible brachial plexus surgeon who has since passed, but he was in charge of gathering a group of brachial plexus surgeons for what was then a casual, yet contentious group of discussions around how to take care of patients with brachial plexus injuries, and it's both adult and kids. At this point, only treating adults, but you know, great discussions. This it's evolved into more of a traditional academic meeting with a lot of, papers and podiums and that kind of thing. But really fun to see people from all over the world who share interest in brachial plexus. Met a few podcast fans, which was really cool. And appreciate all the love that people have for the podcast. Um,
I lost you for a second. That was totally weird. You said appreciate the podcast love, and then you moved on to a different topic, but I didn't hear
Oh
that.
yeah, no, appreciate those of you that listen to the podcast and were kind enough to mention it. I learned a lot at the meeting and brought home a bunch of ideas. And it's great to see international colleagues in different perspectives because you can get into a bit of an echo chamber with your own practice and how things are done in the States. And so seeing how other people do things is very helpful. And then tacked on a few extra days of fun since, of course, we were in Italy. We were in Torino, which is in the northern part, and it just happened to be the weekend of the Truffle Festival in Alba, which is a village up there. And it just happened to be very closely situated to a couple of really great wine regions, Barolo and Barbaresco. So it was a fun time on the back end.
Did your wife travel with you, or is this purely work?
Yeah, so my wife came with me. So she had a couple of days, 3 days on her own in Torino, which she did all sorts of fun stuff. I was very jealous while I was in the conference. And then we took the rental car and drove a little over an hour to Alba, Borolo, and Barbaresco.
Wow, sounds great. Did you present, or were you a listener?
I presented. I shared a paper on our experience from our multi-center plexus group, which I realized that it was very American to me to name a study group Planet, which is prospective longitudinal assessment of nerve trauma, and only have American centers. It's kind of like the World Series, the world champions of the NBA, the Super Bowl, and just completely disregard involvement in other sites. But as you would know, involvement. I mean, you do some work with Canadians for your study group, but it's really hard to do international work, collaborative work for research because of all the the regulations and bureaucracies.
Yeah, it's a really good point. It's really funny, actually. But I'm glad you're able to share your world, United States focused outcomes, early outcomes. And it is interesting. We are expanding our CUD registry, congenital upper limb deficiency. Hopefully, we're going to add sick kids in Toronto as our next major site. But we have gotten IRB approval to add a few sites that are where we perform mission trips. And so hopefully Central America, South America, and Eastern Caribbean. And that'll be really our first foray. We have partnered across the world to help establish other registries, but the goal, of course, is unification of these.
Yeah, absolutely. It's like you're trying to unify all the world titles. Wasn't that a wrestling thing? I can't remember anyway. We shall move on. So we have a great listener email about with a grab bag of topics, and given that Thanksgiving is right around the corner in the U.S., we wanted to talk a little bit about what we're thankful for, including our first sponsor.
Absolutely. The Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job doesn't have to be. Join PracticeLink for free today at www.practicelink.com/theupperhand.
So I'm not even sure if you planted this first question. Um, did we share the listeners?
We did it. That's a great segue. So Chris Gayton, who is in at Ortho South Carolina in Myrtle Beach, has emailed us before and I think brought us some topics in the past. But Chris, thank you for emailing us again. And he was kind enough to thank us for continuing to do the podcast. I feel like it's been, I don't know, like 10 years now or something, right? We've been
Dog
podcasting.
in dog years, maybe a century.
Exactly. But his first topic idea was deciding when to do a carpal and cubital tunnel release together, especially if the nerve studies are normal and the diagnosis is clinical, and also when to add an ulnar tunnel release for a severe cubital tunnel. So I think the first one is pretty pertinent to both of our practices as well as the second one. But do you want to take a stab at the first one, Chuck, about when you do carpal cubital together, especially if you have electrodiagnostically negative result or normal results?
Right. So one thing we know is that if one treats cubital and carpal together, surgically that is, if one treats them together, we can predict that the positive effects of the carpal tunnel will improve will just be a strong influence on patient-rated outcome measures after the surgery. So in other words, if you're trying to better understand outcomes for cubital tunnel, you do that without the confounding variable of also doing a carpal tunnel. And so that's really important. And so the power of doing a carpal tunnel release is important. So when I see a patient, um, the if they clearly have carpal tunnel, whether clinically or electrodiagnostically, it's a no-brainer to treat the carpal tunnel. And trying to unravel whether mild clinical symptoms of cubital tunnel exist, whether they're more than mild symptoms, what the nerve studies show. But if there's any real evidence that there's cubital tunnel as well, and especially if there's sensory changes and there's motor changes without a doubt, I will do both. If the cubital tunnel symptoms are super mild and more subjective, I will give the patient the option of doing a carpal tunnel release, or if it's bilateral carpal tunnel release. I hope that I said that clearly enough. How do you think about it?
I think that was pretty clear. I guess the question I have is how often do you think you see somebody who has a electrodiagnostic test that's normal that has the more advanced sensory or motor findings? I think that, the nerve tests may not be they're okay in terms of sensitivity, but they are pretty specific. So I think put it another way, I think it's uncommon to see somebody who has those advanced motor sensory findings with a normal nerve study. You could have somebody with painful symptoms and paresthesias, et cetera, with a normal nerve study, but the advanced findings I do think tend to correlate with the nerve studies pretty tightly.
Yes, so I totally agree with that. So I think the clinical scenario would be, waking up at night, shaking the hand out, classic carpal tunnel symptoms, and then occasional numbness and tingling that radiates to the ring and little finger, no static changes in sensation, no weakness. In those cases, the typical clinical dilemma for me is bilateral carpal tunnel syndrome and some super mild cubital tunnel syndrome. And I'm going to generalize, but my general approach is offer the patient either unilateral carpal and cubital or bilateral carpal tunnel alone and see what happens.
Now, is that because you're more comfortable making a clinical diagnosis and carrying that on to an indication for surgery for carpal tunnel than you are cubital tunnel? Or is it because of the mode of anesthesia, which is actually, for me, a pretty interesting wrinkle in how I do my decision making?
Yeah, all true. And I'll say that I don't like to do, I hesitate to do a cubital tunnel, a carpal tunnel on one side, and another carpal tunnel on the other side. I think that ends up being a lot for patients' ability to function independently. So I'm usually deciding treat one arm or treat both carpal tunnels. And I think, and I'd love to hear your thoughts on anesthesia and post-op recovery.
Yeah, I think if it's early on, I usually try to non-op a lot of cubital tunnel just because as much as I think we do have a good grasp on how to treat cubital tunnel, what I don't think we understand is how common these kind of symptoms are in general. I think that we know that based on I think a study that you were a part of, I mean, instability of the ulnar nerve, which is related but not completely the same as cubital tunnel syndrome, is pretty common. If you went out to the waiting room, a third of people are going to have instability of their ulnar nerve, which means they're likely going to have, some cubital tunnel type symptoms. Now, whether that rises to the level of, the threshold of getting to surgery is a different thing. And then also, I think that one of our partners, Ryan Calfee, has shown that there are a lot of people, if you ask them to diagram out on their hand where their symptoms are, a lot of people with confirmed diagnoses of carpal tunnel will have kind of a whole hand diagram in terms of where their numbness, paresthesias are. And treating the carpal tunnel for whatever reason, whether it's indirect decompression of the ulnar nerve through releasing the transverse carpal ligament, or something else will tend to help a lot of those whole hand type symptoms. So I think my preference is typically to just say, hey, just do the simpler thing, do the carpal tunnel release. And my bias is probably because I do a carpal tunnel release under local for the most part. And while I've done cubital tunnel releases under local and I'll do it under particular situations still, I think that's a harder surgery under local for all involved. So I think that if it involves, the general anesthesia, sedation, et cetera, it becomes a different discussion.
Yeah, well said. And I know it's surprising, but earlier in my career, I did a fair amount of cubital tunnel and ulnar nerve research before I moved on to more important things. But I'll say that one of the studies, to your initial point, is non-operative care for mild cubital tunnel works. And so nighttime splinting at 45 degrees really can make a big difference, avoiding the hyperflexed elbow resting position. Those things help. And so you and I see this, I think, very, very similarly. What about the question of when to add a distal ulnar tunnel decompression? Despite evidence suggesting that's not necessary for most, I know there are plenty of surgeons out there who still do it routinely. I do not. When do you add a distal ulnar tunnel decompression?
I added for people who have more severe uh, motor and sensory findings on their exam. And then I think picking it up clinically is challenging. So, in that setting of having more advanced motor and sensory, you're doing it because you want to be complete, you want to be done surgically. I think it is relatively rare to have, or uncommon, I should say, not rare, to have bothersome paresthesias because of entrapment at Guillen's canal. We oftentimes do it again to know that we've done the most thorough decompression we can do. Diagnosis is challenging. I think if you're trying to do a Tennell sign in that area, you get a lot of scatter because you're hitting the carpal tunnel. What I've done on my exam is that basically I feel the pisiform and I just go adjacent to it and push, do a Durkin's type test over the ulnar bundle, just proximal to the wrist crease, adjacent to the pisiform, and see if I can get paresthesias into the ring and small finger. Not anywhere else, ring and small finger, not local tenderness, but the paresthesias. Doesn't obviously can't tell you anything about motor. Trying to pick this up on nerve studies is very challenging. If you have a unilateral test alone, because of the physiology and morphology of the ulnar nerve in that level, it's very hard to pick things up on the sensory conduction studies and the motor conduction studies. Unless you needle multiple muscles, you're going to have a hard time localizing a lesion to Guillen's canal in the absence of any sort of hook of hamate pathology or a mass, et cetera. And if you are going to try to diagnose it electrodiagnostically, you do have to get contralateral studies because I think that helps quite a bit. At least that's what our physiatry colleagues, PM&R colleagues tell us. Ultrasound is okay at this. It's not great. Ultimately, it comes down to, I think, your exam and your hunch, and then your decision making in terms of wanting to do the most definitive thing. I think it is becoming more common. It's no secret that Dr. McKinnon is a very influential surgeon in this regard, and people listen to a lot of her advice and look at a lot of her videos. She does have a interesting graph in her most recent textbook showing just over year how many more her level of ulnar nerve transposition volume has been about the same, but there is, and I'll draw it this way for the screen, a rising number of Guillen canal releases that she has done over the year concomitantly. Um, but she doesn't say why in particular. It's not necessarily evidence-based in the way that we would traditionally think about it, but there is a lot of value in that, level 5 evidence. She's done more Guillen's canal releases, so I think more people are listening to that and just kind of doing it. But I don't think there's going to be any sort of comparative research to truly corroborate that practice.
And what we know, again, for the younger listeners, is that when one performs a carpal tunnel release, the volume of the distal ulnar tunnel increases by at least 65% or so. And that is the rationale behind not doing a distal ulnar tunnel decompression in combination with a ulnar nerve treatment at the elbow. And that's why I don't do it. But I like your point of basically a compression test proximal to the wrist crease over the ulnar nerve, trying to separate it from carpal tunnel. And I'll say that if a patient has severe cubital tunnel, or not even severe, but if they have cubital tunnel syndrome and a reactive ulnar nerve at the distal ulnar tunnel, I don't think it's crazy to do it at the same time.
Yeah, I mean, I totally agree. And I think that, the indirect decompression you get after releasing the transverse carpal ligament, that's going to help a lot with the paresthesia part of it, I would think. You know, it's hard for me to believe that the zone 2 part in particular gets a lot of decompression after a transverse carpal ligament release. But I think that's I don't know if we're ever going to get to the point where we understand how much the zone 2 decompression does, because usually now, when you're doing a zone 2 decompression for somebody with severe cubital tunnel, you're also potentially doing a supercharge. So it just gets really, really messy. So, Chris, thank you for that question. I think what we'll do is maybe tackle your last question and maybe save your second one for another day, because that way we can talk a little bit about what we're thankful for. So, Chuck, this is way more in your wheelhouse. I think you planted this question. Just had a SL repair after the episode. Can't seem to get a dry scope to work or figure out how to pass suture. I opened it and did an internal brace, which looked good. So, do you have any thoughts about how to, perhaps tackle this arthroscopically, or should one just consider going right to the open?
So, getting to your point where we started, I think our European colleagues have a lot to teach us regarding wrist arthroscopy and the use of dry arthroscopy. I would say in the last year or two, maybe 20% of my scopes have been dry, and they typically are in those cases where I'm planning to do an open repair or reconstruction. It just makes it so much easier. At least with the equipment that I have access to, it's hit or miss on the picture. So, the steps are the same. You put your scope in, put your shaver in. I will attach a syringe as the inflow to the scope, and then occasionally flush fluid into the wrist joint, which I really think can be helpful for visualization. But in certain patients, the picture is perfectly clear. You see everything you need to see. If you're worried about the SL, you can get a good sense of the SL. You can debride if you need to. I personally don't find it all that helpful if I'm expecting a TFCC repair, but especially for radial sided pathology, especially in patients where I'm going to open, I do think dry arthroscopy makes a lot of sense.
And do you have any particular pearls about passing suture through the dry scope? Do you have easy ways to do that?
Yeah, I don't. You know what we need to do? We need to bring Sanj back on. There has been at least one or two other comments how great the episode with Sanj Kakar was. Let's bring him back on and talk about some techniques for arthroscopically assisted or arthroscopic repair of SL. What do you think?
I think that'd be great. We need to figure this out. I just saw a patient in clinic the other day, definitely not in your age group. She's over 65, who's referred to me because she has findings suggestive of a slack wrist. And I was thinking we were talking about how she got there, and SL, and she's asking, well, why can't she repair the ligament? And we had this nice conversation that people like Chuck and Sanj are trying to figure out how to repair these ligaments and really ward off the terror that is slack wrist.
All right. Well, we'll get Sanj back on maybe in December, but we'll get him back on. Before we jump into everything that we're thankful for, did you know the Upper Hand is sponsored by Checkpoint Surgical, provider of innovative solutions for peripheral nerve surgery? Successful nerve surgery, Chris, begins successful nerve repair begins with preparation, and Checkpoint offers a disposable instrument to aid and improve nerve preparation.
The Checkpoint Edge nerve cutting kit employs circumferential constraint to maintain the nerve's natural shape during transection, helping to preserve fascicular groove alignment and tissue integrity. To learn more, visit www.checkpointsurgical.com. Checkpoint Surgical, driving innovation in nerve surgery and apparently nerve cutting.
I Look, what do I know? A non-nerve surgeon. I think this is relevant. I think that the non-destructive cutting actually is helpful, and how we do that matters.
I do think it matters. It's interesting. One of my ways of torturing, I mean, teaching our trainees is to have them cut the nerve over a tongue depressor. It's what I typically use, as I'm sure you have been trained in the same way, uh, with the sharp blade. And ideally, it is one relatively seamless motion, a single cut on the nerve. Because the more chops you take at that nerve, obviously the more you're trimming back, and that can certainly affect the tissue quality. As you're trying to get that nerve coaptation just perfect.
Do you use a specific blade, like a 10 blade or an 11 blade versus a 15 blade?
I like a 10. I admit I get impatient. Sometimes I forget to ask for the 10 blade ahead of time, and I'll use a 15. But what I like about the 10 is that you can make it most like a guillotine. Because if you have the nerve on a tongue depressor, you can take the edge of that 10 blade and then just kind of get the tip all the way back and then just slice down. And I think that if you set it up perfectly, you have somebody holding the edge of the nerve that you're going to cut with, and you can use an Adson at this point, somebody else holding the tongue depressor. Then you can even take your other hand and put pressure on the gentle pressure on the healthy side of the nerve to allow that cut to be just perfect. A really nice illustration in my favorite nerve book, Dr. Gelberman's Operative Nerve Repair and Reconstruction, showing exactly how to do it.
Yes, I think this conversation is illuminating for many reasons. One is the difference between Chris and myself. Here are two examples. Number one, I grew up in Alabama, so we call it a guillotine, not a guillotine. And number two, I call it a popsicle stick, not a tongue depressor. So fancy.
What kind of, honestly, have you seen a popsicle stick? It looks nothing like a tongue depressor. I don't know what kind of popsicles you have out in Alabama, but yeah, a tongue depressor is a much wider instrument. If you're trying to cut over a popsicle stick, you just wouldn't, what nerve are you at? A digital nerve. You can cut over a popsicle stick.
Yeah, maybe my popsicles are different than yours. We should move on, probably. What are we thankful for, Dr. D?
I am thankful for the fact that you continue to tolerate me on this podcast. You clearly pull the weight here in terms of gathering listeners and viewers on YouTube, doing all of our technical work while I am purely here for to be your foil. So I'm thankful. That's number one. That is number one that I'm thankful for this year.
Well, I'll build on that and say we're going to try to get to seven. I think we have many, many, many things to be thankful for, but our goal is seven. So I'll build on that. The podcast is a labor of love. We are grateful for the listeners. For you and me, we don't cross paths ever on a daily basis. Occasionally in the anatomy sessions, but we just are in different locations, and so. Part of the joy of this is you and I get to hang out intermittently over Zoom, which is fun. And obviously, we both have enjoyed the podcast, and the interaction with listeners is fun for us, and hopefully that not only continues but expands.
Yeah, absolutely. I think it is fun not expecting to hear random comments when you're at a meeting. Being like, "Oh, now I know what you look like. I'm used to hearing your voice." So that's always my favorite one, to be honest with you. But it does, those comments are really, really welcomed. So we do spend some time that we could be doing a lot of other things doing this. So thank you for those of you that mentioned that.
Yeah, I'll stay on the work theme and say, I'm really grateful for our hand division. We recently expanded. Jason Strelzo joined us from the University of Chicago and has really already made an incredible impact. I was working with one of the residents on Friday, and she was going on and on about how wonderful he is and how he's going to only make us better. So we have 8 great hand surgeons and a real commitment to education and a real commitment to each other. And so I am absolutely grateful for that.
Absolutely. And he has made a difference. The wait time is now 2 months as opposed to four. As I've heard from patients. Well, it took me 2 months to get in here. I was like, that's really good. We just hired a new partner. He's wonderful. He's helped a lot with that.
Yeah, it's so funny. I spent a lot of time, more time than I should, looking at Press Ganey scores. And the two things, Dr. D, that always are marked as negative comments. Number one, I didn't see you wash your hands. I'm like, still, like, oh my God. I know we all do it. It's just the patient needs to see us doing it. But the other is great visit, but took me 2 months or 3 months or 4 months to get in. And we don't like it either, is the message to patients. We're
Right.
trying.
To your first point, it's interesting to see the number of steps that have been taken to make sure we all wash our hands, which is of course super important. But like you can't go like more than 3 feet without a bottle of hand sanitizer. And I actually don't even shake patients' hands half the time because I'm still rubbing the damn hand sanitizer. And I'm like, sorry, we're gonna get a clean handshake. It's like very clearly showing you I am, I have this nervous tick where when I open a door, I will get the hand sanitizer, and I'll get it and then I'll get it again. Like but as I'm walking in the room, because sometimes when I'm knocking on the door, I'm talking to somebody else. So I'm super, super sanitized when I go into those rooms. And we can have this conversation on Press Ganey another day, but I still have not cracked the code in terms of how to be one of the top patient satisfaction providers because honestly, you score super high and then you look at your percentile relative to your peers and like, the hell are they doing that I'm not doing?
Yeah, we can talk later. I can share some tips.
Yeah, you could definitely teach me. Because I clearly need just that in my life is trying to chase that score too. So next thing I'm thankful for, I guess we've talked about our podcast and each other and our partners. Thankful for health. When you're not in health, it does certainly make you realize, when to appreciate what you have. And right now, as I'm still on the tail end of yet another cold, because all the kids' stuff that they bring home, I'm thankful for the fact that this is what I'm worried about.
I love that. I love that. I'll build on that with a funny story and related to recent travel. So I recently went up east. My daughter is a runner, and she was running in the Ivy League Championships cross country, and had a wonderful trip. She had a good race. She's finally healthy and improving, and so I'm grateful for that, for health. And cross country, for those of you who don't know the sport or haven't ever been, is really fun as a spectator sport because you spend time running around the course trying to get a glimpse and yell words of encouragement to your child and her teammates. And I am now about 10 months out from my knee replacement, and I've started to jog a little bit here or there, but the most jogging I did was running around trying to yell, run faster to my daughter. And I felt pretty good.
That's awesome. I will tell your knee surgeon when I see him later today, if I get to that point, that you're running. Because I think feel like this has been a journey for our podcast listeners, hearing about your knee replacement and your recovery. So I'm glad that you are now able to run slash hobble around the cross country course.
Yeah, it's funny. The two funny parts. One is when the old people run around, it's this slow lumbering jog. And then you've got the other college students who are there to cheer on their teammates or their friends. And it's a really amazingly cool event. And they're like sprinting all over the place. And I'm just trying to get from point A to point B to point C. But my funny other story is, so we were on the East Coast. This was back actually when the time changed, the daylight savings time. And those international colleagues listening are shaking their heads now, wondering why the heck we still do daylight savings time, but we do. And so I had set my watch an hour ahead because St. Louis is in the central time zone. We went to the East Coast for the Eastern time zone. And so I came home and the time changed overnight, and I really try to sleep later and don't do a good job. So I looked at my watch first thing, and it said 6:45. And I'm like, oh my God, that's fantastic. And then I realized that it was daylight savings, so it was really 5:45. And I'm like, okay, well, that's pretty good sleeping in for me. And then I realized my watch was still on the East Coast time and it was 4:45, which is not what I was going for.
Oh, so it just I've tried this year to be better about sleeping. What is an average night of Chuck Goldfarb hours of sleep?
5.5 is probably about average. What about you?
I try to get to 6, but I certainly don't always do that. And my wife's a bit of a night owl, so like that overlap is pretty tight in terms of before I become a pumpkin and while she's still up and not still doing stuff. So and there's always obviously the race to get the kids to bed so we can actually hang out for a little bit. So
It is interesting. My wife and I are on different time schedules whatsoever, but thankfully I can fall asleep when she's not, and I creep out of the room in complete darkness every morning. But yeah, if I 6 is good, and on the weekends I am a huge proponent of the nap, and that gets me over the hump for the week.
very, very, very nice. So funny daylight savings time story. It is not only a U.S. practice still. So when I was in Italy for the Naracas meeting, we actually had daylight savings time over there, and then so which was great. And then the weekend that we got back to the States following, got daylight savings times again. So I got double the fall back in terms of hours of sleep that were restored to me. But interestingly enough, the hour of sleep that was restored to me was actually like I came to the OR for an overnight case right before the time change, and we ended the case right as the time changed. So I feel like I drove in and left at the exact same time, which was interesting enough.
Yes. This episode is dropping just after Thanksgiving, which is sort of the point of our what we are thankful for. So thankful for family for sure. For Thanksgiving, we drove down to Alabama where my entire family still lives, and it's always fun. And I look forward, you're hearing this after, but I look forward to seeing the family and being with family, the extended family that is.
Yeah, yeah. So one of the things I'm typically thankful for is I love, and this is gonna sound weird to some, I love Thanksgiving meal in the States, which, yeah, I know that it's culinary wise not the best food. Like a lot of people really want to pass on it, but it's the nostalgia part of it that I love. It was bad. It was so bad that like last year when I went, and I think we talked about this. I went to the Philippine Orthopedic Association last year and presented. And we extended the trip during the week of Thanksgiving. So we came home and it was, I think, like the Saturday after Thanksgiving. The entire house is passed out, jet lagged. At the end of the day, the kids slept until I think like 3:30 or 4 o'clock in the afternoon. They were so jet lagged. But I, of course, got up. It was like 9 a.m. or something like that. And I had coffee. I worked out. Everybody's still sleeping. So then I went to the store, came home. I made a individual sized Thanksgiving meal. It was like a turkey breast, it was stuffing, it was sweet potatoes, it was mashed potatoes, green beans. And I just was hungry and I wanted to eat this because I missed it. And I made it and ate it. Everybody's still asleep. That's how much I love Thanksgiving food. But this year we'll be, and again, we're dropping this right afterwards, but we'll be spending our Thanksgiving in Mexico. So the second year in a row where I've been deprived of proper Thanksgiving meal.
I love that. Thanksgiving, and this tells you, you and I different with culinary appreciation. I eat to live. You, at least in part, eat live to eat. I Thanksgiving is far and away my favorite meal of the year, favorite holiday. So if we had to list them, Thanksgiving, Christmas, Easter, Fourth of July, what's your favorite holiday meal aside from Thanksgiving?
Oh, uh, I like Christmas. I mean, as a Filipino, Christmas is a very special holiday for our culture, given a lot of Filipinos are Catholics. So I think that is always a fun meal. A lot of our gatherings are, like many cultures, based on food, which is probably why I am the way I am. So I think Christmas is a favorite one. Interestingly enough, we talked earlier about Halloween and the St. Louis tradition on top of the jokes thing is making pots of chili apparently and just like sitting out there and eating chili while by a fireside while kids are coming up and telling you jokes, which I'm sure will be my future. But made some really interesting pots of chili for Thanksgiving or for Halloween this year. So that was fun. Had a nice little chili bar. So I do like that holiday. But you could name a holiday and I could find a food. I mean, so at this point, this will have passed. But one of our close friends, the Burks family, is hosting a election night themed party, which with foods from swing states. And I'm like, I don't know if I really want to share this moment with a lot of people. I think I need to be by myself or just with my wife while we watch returns on the election. But it's going to be foods from swing states. So again, you could make a culinary festival out of any occasion.
Yeah, that is tough. I don't know that I could attend such a gathering either. I know my wife could not. And I will also add that in visiting my daughter, we flew to Philadelphia in the state of Pennsylvania, and I cannot imagine living in a
Oh, it's
swing
crazy.
state, and every billboard was one way or the other. It was unfathomable, and thank goodness Missouri is not considered a swing state, although we'll see what the election looks like this year here.
Yeah, no, so I mean, continuing on the themes, thankful for the chance that I voted this year early, and we brought my wife and I went and we voted early, and we brought the kids with us, which was a really interesting experience. So they had to answer some questions about some, campaign signs that were out there as we were waiting in line. But we drove out about 15 minutes to try to beat a few lines, and we still waited about an hour in line to vote on a Saturday morning. But it was at a library, so the kids were able to go to the kids section. I actually pulled a couple of books and magazines as we were progressing through the library, which made the line a lot more palatable. But yeah, thankful that had that opportunity and they got to share that with the kids, which I think answering questions about voting and why you do that and that kind of thing, and appreciating what we have here in the U.S.
Absolutely, yeah. Despite the challenges of our system, which seem magnified today, I agree with that. I will say that my daughter is in college, and she's in the state of Wisconsin, which is a swing state, and she voted there. And it was known that she was a first-time voter, And when the lady registered her, that she announced it, and everyone started clapping, which is really kind of heartwarming. Um,
They did the same thing. They did the same thing where I voted. That was so super cool. And then my wife and I started thinking about the first presidential election that our kids are going to vote in, which I believe is going to be 2036, which is crazy. So,
that's really funny. Well, so much to be thankful for. We barely scratched the surface, but it's been fun chatting. I don't know if you have any other thoughts to close.
well, I did want to say, we are thankful for you guys, the listeners, guys and gals. So feel free to email us, handpodcast@gmail.com. Tell us what you want to hear. I think even though we talked about topics several times over the years of doing the podcast, I know that our thinking has potentially changed over time, and maybe yours has too. So feel free to let us know, what else you want to hear about, if there are other wrinkles or updates you want to hear about. And don't be afraid to push us on topics or our approaches to things because we certainly know that we do things a certain way here. Even though Chuck and I vary on a number of things, we probably do agree on more than we disagree. So if you have a different perspective, please feel free to share it.
Absolutely. Well, until next time, thank you.
Uh, all right. Thank you. Have a good one.